Hello, everyone. I'd like to talk to you about ectopic pregnancy today. I'm Eli Weshef. I'm a board-certified reproductive endocrinologist and fertility specialist, and this is a very important topic. It's scary, both to the physician and to the patient, and fortunately, it occurs rather infrequently, even though 1 to 2% in the general population in pregnancy and a little higher following in vitro fertilization pregnancy. The good news is that, first of all, the mortality rate of ectopic pregnancy has been declining over the years because we now have the availability of diagnosing it earlier and treatment tools that do not always necessarily involve surgery. And so in my early days, it used to be typically an emergency. In this day and age, it's still an urgency and sometimes emergency, but many of them can be managed even without surgery. So, ectopic pregnancy. Ectopic means out of location, pregnancy that occurs in a location other than inside the uterus. The most common, of course, is the fallopian tube, and so oftentimes we use the term tubal pregnancy interchangeably with ectopic pregnancy, but the other locations for pregnancies that are considered ectopic are in the C-section scar on the ovary, in the cervix, or even in the segment of the fallopian tube that joins the uterus, or even in the abdomen. These are rare. Imagine the disappointment, concern, and otherwise of people who have been trying hard to get pregnant, whether it's with or without in vitro fertilization, but especially with in vitro fertilization. And now we have a pregnancy that we cannot determine whether it is in the fallopian tube or in the uterus. One of the disadvantages of being able to diagnose things early with the assistance of ultrasound and blood levels of HCG and progesterone is that oftentimes we catch the pregnancy early and we cannot see a gestational sac, evidence that the pregnancy is inside the uterus, and so oftentimes we term it pregnancy of unknown location. And of course, the question arises, is it a normal pregnancy? Is it going to be a miscarriage, or is it in the fallopian tube? So, how do we diagnose ectopic pregnancy? Clearly, anybody who's pregnant, and I know this may seem like an exaggeration. It's not. Anybody with a positive pregnancy test is considered to have ectopic pregnancy until proven otherwise. It's pretty radical because now we're casting a very broad net, and the majority of them will end up having normal pregnancy, but the sense of suspicion, especially by the physician, is that we need to follow the pregnancy early. Especially be alert to symptoms such as abdominal pain, vaginal bleeding. And so, you got pregnant, let's say after an elaborate process like IVF. You have bleeding. And then in a panic, as you are justified to do so, you call your physician. The physician hopefully will see you very early as possible for an ultrasound. And sometimes it's early enough that the pregnancy inside the uterus, what we call the gestational sac, is not yet seen. We also have to consider your symptoms. So it's not just vaginal bleeding, but it's pain. But it is vaginal bleeding in the first trimester of pregnancy, whether you did IVF or not. It's, first of all, very common. A third of all pregnancies will have some bleeding in the first trimester, and the majority of them will end up fine. Some of them, however, may end up being in the fallopian tube or ectopic pregnancy, tubal pregnancy. And the elegant thing about ultrasounds nowadays that when your HCG level reaches a level of about 1500, we should be able to see a gestational sac in the uterus if it is an intrauterine pregnancy, as it should be. And if we don't see it, it still could be either a miscarriage or an early pregnancy, so we have to follow you very carefully. The combination of clinical symptoms, pain, bleeding, or lack thereof, ultrasound findings, whether or not we find a gestational sac in the uterus elsewhere, or we find a mass by ultrasound on one of your ovaries, need to alert us to the possibility of tubal pregnancy. So let's say we follow the blood levels of HCG and they're rising appropriately, but your progesterone level is low. So we are concerned about the welfare of the pregnancy. We have to follow you very carefully. Sometimes maybe twice a week by ultrasound, because eventually, and of course by blood level, because eventually we should be able to see when the level exceeds 1500, and especially 3000 or beyond, we should be able to see something in the uterus. If we don't, it's an ectopic pregnancy until proven otherwise, even though many of them will be simply an impending miscarriage. So let's say the level has gone up inappropriately. Typically, we'll look for the HCG level to double every other day. If it doesn't, we are suspicious of an abnormal pregnancy, whether it's impending miscarriage or tubal pregnancy. So, we don't see a gestational sac. Your level is 3,500, say. And we have now a follow-up where the level has been rising very inappropriately or plateauing, and you don't have any symptoms. There's really nothing by ultrasound that we can see, and your vital signs are stable. What can we do? This is either a tubal pregnancy or an abnormal pregnancy that is doomed to be lost, what we call pregnancy of unknown location. We can treat you with medication, primarily methotrexate. It's an injection in the muscle, typically given once or maybe repeated in a week, and that is a fairly effective way to make the pregnancy go away. Obviously, the main concern is not to interfere or intervene when you might have a normal pregnancy. That's a dreaded complication that we see, and so we only offer it when we're absolutely sure that the pregnancy is not heading in the right direction. If, however, you develop significant pain or any evidence of bleeding inside the abdomen, or vital signs become unstable, then it's time to intervene, and clearly surgery is one of the options at that time. With regards to surgery, typically it's laparoscopic surgery. Whether we remove the fallopian tubes or we remove the ectopic pregnancy from the fallopian tube, and uncommonly we what we call milk the fallopian tube, squeeze the fallopian tube so the ectopic contents can be removed without removing the tube or making a slit in the fallopian tube, what we call a salpingostomy. So over time, I've seen different trends. In the old days, we used to remove the fallopian tube automatically. Then in the 90s, we used to make a slit in the fallopian tube, remove the ectopic, and the fallopian tube oftentimes would heal. But remember this, once you had an ectopic, there is a risk for another ectopic. And so nowadays, the tendency is to remove the tube again. So clearly, ectopic pregnancy oftentimes occurs because of damage to the fallopian tubes, oftentimes because of infection or endometriosis, most likely infection though. And so the tube is still damaged and can serve as a location for a future ectopic pregnancy. So reduce that, especially if we see the other fallopian tube and it's normal, we remove the fallopian tube if you have a tubal pregnancy. If we treat with medications, methotrexate usually, the fallopian tube actually will become as open as it was before. Now, you still have risk for ectopic pregnancy, but at least you did not require surgery. And by the way, we sometimes use expectant management, meaning no intervention, but very, very careful follow-up to make sure that you don't develop symptoms that are worrisome. So let me summarize by saying that ectopic pregnancy is a very serious complication. Occurs about 1 to 2% in the general population, maybe 2 to 4% in following IVF. In this day and age, we can diagnose it early using ultrasound and sensitive blood levels, and the trends of the blood levels to rise. Treatment can be medical, meaning injections with methotrexate, or surgical, and oftentimes the surgical treatment involves removing the fallopian tube altogether to reduce your chance of having another ectopic pregnancy. So with that, I end, and I appreciate you listening.